One. Please start, sir. We are live.
So very good evening, all the doctors. We would like to welcome you all to the session of Crevast Academy. So as all of you are aware, at Aries, we believe in, we have an ethos of power of empathy, truth of science. So through this ethos, we always think of a patient care initiatives. So we are very proud to share with all of you that we are #1 company when it comes to patient care. So through our various patient care initiatives, we have been supporting a lot of patients. To name a few initiatives, we are running Holter on Call, ABPM on Call. More than 7 to 8 years, we have been running this. And in thousands and lakhs of patients have benefited through all these initiatives. Now, coming to Crevast Academy, these are some of the glimpses of the earlier Crevast Academy. This initiative we started from last year April, and we have almost completed 1 year. And these are 10 different sessions which happened last year. To name a few, like the first session was on statins essential for diabetes heart, statin optimization need of the hour, the battle against arterial plaque with statin, the jury on statin-associated muscle syndrome, the hidden threat, low LDL yet high CV risk, high-intensity statin therapy, unified solution to CVD management, intensity matters, deciphering its significance in statin therapy, unraveling the lipid puzzle, the lipid management puzzle, the aligning the expectations with the reality, and the last one was CVD epidemics in India. And after all these sessions, today we are here on our 11th session. And today we have our international speaker with us, and Dr. Aditya Kapoor, a leading cardiologist of India, and Dr. Sanjeev Shah moderating the session. The topic of today's session is Navigating Heart Health, Key Factors Shaping Cardiovascular Outcomes. And after this session, we will have a panel discussion on decoding the statins and cardiovascular health. So today, today's moderator is Dr. Sanjeev Shah. He is an endocrinologist from Nanavati Max Super Specialty Hospital, Mumbai. He is an academic clinician in private practice since more than 40 years. He has worked as a pharmacologist attached with KEM Hospital for more than 5 years. A researcher with a lot of global trials in diabetes since last more than 20 years. More than 50 original papers and 20 book chapters are under his name. So, Dr. Sanjeev Shah, we are very happy that you are there with us moderating this session and all these sessions of Crevast Academy. Over to you, sir. Thank you very much, sir.
Thank you, Aries team, for inviting me to run Crevast Academy. It's my pleasure to have international speaker today in Crevast Academy. Next slide, please. Our subject has been introduced by Khushbu Patel. So our expert today is Dr. Zahid Ahmad, who has been a lipid expert at UT, that is University of Texas Southwest in city of Dallas. UT Southwest is very, very popular center when it comes to a subject of lipid biology, where from the time of legacy of Goldstein, Brown and Statin Nobel Prize winner working at the same center, followed by a leading authority, Professor Scott Grundy, and subsequently even PCSK9 discovery happened with Helen Hobbs in the same university. Dr. Zahid Ahmad had been introduced to lipid and familiar hypercholesterolemia long back. He's associate professor in Department of Internal Medicine, running 2 major lipid clinic in the same institute, as well as a very important subject of a Southeast Asian metabolic studies and research happening at the same place. His research has been funded by NIH, Department of Defense, American Heart Association, and some other private funders. He's trying to run a good clinic where there is a big challenge with familial severe hypercholesterolemia, which requires multiple different therapies in addition to statin. And so he is a pioneer, is part of many research projects. We look forward to his deliberation on how CV outcome can be changed using lipid-based therapy. After his talk, next slide, we would have 30 minutes of panel discussion. In the panel, Dr. Aditya Kapoor would join, who is currently the professor and head of cardiology at prestigious Sanjay Gandhi Postgraduate Institute of Medical Sciences at Lucknow. He had been trained in Delhi at different institutes. He is a cardiologist trained in Lucknow, Commonwealth Fellow at St. George Medical College in London, past director of coronary care unit in Australia, fellowship of multiple different cardiology society and association, and intervention in coronary as well as electrophysiology is his interest. So he's going to share his knowledge in Q&A session in interactive format after the lecture. With this, I would invite Professor Zahid Ahmed to take over. Dr. Zahid is going to share his slides. I request you to share your slides, please. Over to you, Zahid.
Thank you so much. That was a very kind introduction. I'm very lucky to work at an institution that has a very strong history in lipids and cardiovascular research. And so it's an honor actually to be here and talk to you about that. Let me just start with what is the burden of cardiovascular disease. Cardiovascular disease still remains a leading cause of death globally. There's 18 million people who died from cardiovascular disease a year, and that's about 30% of all global deaths. It remains the biggest killer in the world, despite all the other things that we have going on, and despite years and years of research. You know, we have 50, 60 years of research. We have multiple medications that reduce cardiovascular disease risk, but for whatever reason, we are not able to eliminate it. And unfortunately, in South Asia, it's even worse. This is some data from the UK Biobank, and they looked at the incidence of atherosclerotic cardiovascular disease. So in this biobank, they actually followed people over time to see what the incidence is, not prevalence, but incidence. How often does it happen? And in this biobank, they have 8,000 South Asians and about 500,000 European ancestry individuals. And as you can see with this hazard ratio plot, the risk of cardiovascular disease in South Asians is twice as high as whites or as European ancestry individuals. And not only that, but it tends to happen at younger ages. So the plot on the right is the probability of having a myocardial infarction and being less than 40 years of age. And in black is those who are South Asian ancestry, and in gray is the other countries. And unfortunately, we have this much higher risk of developing cardiovascular disease at a young age. It's happened in my family. It happens in many of my friends' families who are South Asian. And I'm sure many of you, all of you probably know at least one or two people who have had an MI before the age of 40, or you've had patients, many patients, if you see these patients who have had an MI before the age of 40. So how do you identify people who are at high cardiovascular risk? Well, we have traditional cardiovascular risk factors. These are pretty universal. Regardless of what ethnicity or race you are, what country you come from, these things we know increase your risk of cardiovascular disease. Some of them are modifiable. So tobacco use, blood pressure, cholesterol, which is what we're going to focus on today, and then diabetes, which I'll show you is actually part of the problem in South Asians. Then there are some things that we just can't modify. We can't modify our genetics. You know, our genetics is what it is. Many of us that are higher risk of cardiovascular disease, we may be at higher risk of hypertension, we may be at higher risk of having high levels of lipoprotein a, which I won't get into detail, but that is something that in South Asians can be higher than other groups. We can't change our age. I wish we could, but we have yet to figure out how to reverse age or anything like that. We can't change our gender, at least not with regards to reducing our cardiovascular risk, and we can't change our ethnicity and race. Now, what's different about South Asians? We often talk about this problem called the skinny fat problem. So in most people, when they get to level D here, that is when we may see, when they get to level D here, that is when they may see the cardiovascular or the metabolic issues of obesity. You know, having slightly high triglycerides, having lower HDL, pre-diabetes or full-blown diabetes. the hypertension, all of those things typically happen as people gain weight. For South Asians, though, we just have to gain a little bit of weight. So column B is supposed to represent a South Asian or a person who has gained a little bit of weight. This is all we need. We get the same metabolic issues. And much of this is related to the breakdown of weight. So some of it is bone, some of it is fat, and some is muscle. Unfortunately, in South Asians, we tend to have more fat and less muscle. And because of that, most likely, we are increasing our risk of cardiovascular disease. And that part of that is genetic, part of that is environmental. It may be related to diet, it may be related to exercise, sedentary lifestyle, things like that. But that is a huge problem. If you have excess fat, it will go somewhere in the body. And unfortunately, it becomes what we call ectopic fat. You can have a normal weight, a BMI of 23, but in a South Asian, that may be overweight. And in the US, we talk about a BMI of 23 is overweight for South Asian, BMI of 25 is obese for South Asian. Whereas every other ethnicity and race in the US, 25 is considered overweight and 30 is obese. So the whole scale is shifted. And what happens with this ectopic fat is that you deposit it in places. You deposit it in the muscles, in the liver, which unfortunately causes fatty liver, which has its own problems. You develop a lot of visceral adipose tissue. You can get perivascular fat, pericardial fat, myocardial steatosis, which essentially is fatty heart, and fat around the pancreas as well, or renal sinus fat. And all of these things cause metabolic issues as well as vascular disease. And if we look at what probably sticks out the most is an excess risk of diabetes. This is data from 2 studies in the US, one called Masala, which is mostly in California and also in Chicago. And they have enrolled 2,000 to 3,000 South Asians in their study. And we compared it to another study called MESA. MESA is a study done in mostly the southern US and in the state of Mississippi. And that has multiple ethnicities and races. And if you look at the data in both men and women, the prevalence of diabetes is significantly higher. And this data is adjusted for BMI, socioeconomic status, waist, traditional risk factors, everything. Despite all that, the prevalence of diabetes is higher, and that's likely because of these different issues with body weight and the skinny fat problem. So we need to intervene. We need to do things to reduce the risk of cardiovascular disease. And so it is quite important. And as I mentioned earlier, the things that are modifiable include cholesterol. And that might be the one thing that the easiest target, actually, because we have multiple generations of drugs now that can reduce cholesterol. The importance is that cholesterol, which is mostly carried in LDL, is what causes the plaque buildup, and which eventually leads to cardiovascular disease. And unfortunately, in the worst case, MI or even sudden cardiac death. And the pathophysiology is that LDL migrates out of the blood vessels. The cholesterol makes its way into macrophages, forms these foam cells. These foam cells then deposit in the intima wall and create a cascade of inflammation and other things that unfortunately could lead to these plaques breaking, which would then cause an acute myocardial infarction. Or it could be stabilized, or it could not break, but you could get stable angina. And the correlation between cholesterol, especially LDL cholesterol, and heart disease is extremely strong. This exists in any data set that you look at, whether it's a genetics data set or epidemiologic data set, and in any country in the world, it doesn't matter. As you age, that risk of cardiovascular disease goes up, and it goes up as your cholesterol goes up. And for every 1 millimole increase, the risk does go up quite a bit. And we talk about cumulative exposure, or lifetime exposure. So the more exposure you have to cholesterol in your life, the higher your risk of cardiovascular disease. We have amazing evidence. I mean, unbelievably consistent evidence that reducing cholesterol reduces the chance of cardiovascular disease. This is data from multiple cholesterol-lowering studies. This is almost all statin studies. Some studies in here may include ezetimibe, but almost all statin studies. And what you see here is both secondary and primary prevention studies. The relationship between lowering cholesterol or lowered cholesterol and cardiovascular disease is linear, almost linear. It does kind of plateau off towards the bottom of this bottom left side, meaning that at some point you do get a little bit less benefit, but you still get benefit. So the lower the cholesterol, the better. There seems to be no doubt about that in terms of every single study done with cardiovascular outcomes of a lipid-lowering drug. So what are the best lipid-lowering agents? To date, the ones that are most studied, the ones we've had around almost the longest, and the ones that we are very, very confident in are statins. This is a little bit about the history of statins. In case anyone is not familiar, statins were actually not discovered in Dallas. Many people think they are, but they weren't. They were discovered in Japan. A researcher there named Akira Endo identified a antifungal agent that lowered cholesterol, and that was statins. His hypothesis was that there must be some fungus that actually protects itself by reducing the cholesterol of whatever attacks it. And so he did a screen of thousands and thousands of fungi and found one that did actually reduce cholesterol, and that's how statins were born. They didn't actually take off right away. In fact, for years and years, people thought that statins would make everyone crazy. They thought the statins would kill people because it wasn't clear at the time why lowering cholesterol would help. It wasn't even clear that higher cholesterol made a difference. And so that's where one of my mentors, Mike Brown, and his colleague, Joe Goldstein, they did some seminal work in proving that higher cholesterol is bad. And they did it in children with homozygous familial hypercholesterolemia. They showed very clearly that these individuals have a defect in the LDL receptor and that they're at higher risk of cardiovascular disease. In fact, some of them have had cardiovascular disease as early as 5 years of age. And that opened the door for statins to be used. And as I mentioned, they were almost killed several times, but investigators at UT Southwestern and other places got their hands on them and did some clinical trials and showed that they are safe. And then it took off. You see here, studies for secondary prevention, primary prevention, and then what we call now, I guess, the statin plus era, meaning that almost every study of a lipid-lowering drug must be add-on to statin because that is the standard of care. The data for statins is so strong that we really emphasize that as a first-line therapy. And statins lower cholesterol. Depending on the intensity and which statin you use, you can lower cholesterol between 18 and 55%. They lower non-HDL cholesterol, which is all the cholesterol in the body or lipoproteins that can cause cardiovascular disease. In many cases, non-HDL is actually a better marker than LDL, but we're focusing today on LDL for the most part. And people with normal triglycerides, they can lower their triglycerides. And in some people, the HDL goes up too. And as I mentioned, we are in kind of the statin plus era. The statins are the cornerstone for combination therapy. Almost all of the studies done on this slide are studies of newer drugs that reduce cholesterol, and they are almost all with add-on therapy. They're almost all add-on therapy, meaning that to be in a study, you have to be on a statin already. To be in a placebo group, you have to be on a statin already. The one exception to this may be the CLEAR outcome study in the bottom left. That's a study of a new drug called bempedoic acid, which was tested in mostly people with statin intolerance. In that study, you did not have to be on a statin. But that study again confirmed that lowering cholesterol is better. Even if you can't take a statin, lowering the cholesterol with something else reduces cardiovascular disease risk. So unfortunately, throughout the world, even in the US, even in Dallas where I work, a very high proportion of people who should be on statins are not on them. And there's many reasons why. Some of it is knowledge. Some physicians, unfortunately, don't know that statins can be used in many people. This is some data from the US and other places in 600,000 people who already have atherosclerotic cardiovascular disease. And unfortunately, as you see, only 22.5% are on a high-intensity statin. Every guideline in the world, doesn't matter where in the world you go, every guideline says that if you have atherosclerotic cardiovascular disease, you should be on a high-intensity statin. If you have a lot of risk factors for cardiovascular disease, you should be on a high-intensity statin. And some of the people who, for whatever reason, don't tend to get high-intensity statin are women, and some people with stroke rather than MI, and some people with peripheral arterial disease rather than MI. And so we know a few of the things that may lead to less thinking about statins, but we still have a lot of work to do to make sure the statins actually get out there. This is also some reasons why people either decline or discontinue statins. Some of it is from the physician. Some physicians don't think about it. They don't give a prescription. There's also an issue of long-term adherence. In the US, there was some fantastic data published by pharmacies showing that 1 year after being prescribed a statin, many people who were prescribed actually were no longer on it. And for the most part, it was just because the prescription never got renewed. It was not because of a problem with the statin, it just never got renewed. Cholesterol, for better or worse, it doesn't cause any acute symptoms. And people forget about it. And physicians forget about it. And so it is very important that we keep in mind that we need to make sure that we keep our patients on a statin. Some people do have adverse reactions. About 5% or less will have some kind of side effect of statins, although for the most part, they're very manageable and we can deal with it. Affordability in the past was an issue, but now 6 out of the 7 statins that we have are generic. And so now, affordability is not much of an issue. Lack of patient knowledge is an issue. I would actually say it's misinformation. If you ever go on TikTok or Instagram or Facebook, you will see so many people talking about how bad statins are. And that's just not true. All of that is misinformation. Most of those posts are done by people who are not in the medical field or are dentists or something else that really has nothing to do with treating cholesterol. Every expert, every physician who understands this realm of knowledge will tell you that statins are by far the best drugs for reducing cardiovascular disease that we have. And then in some cases, statins may not be accessible, although nowadays it's pretty much, in the US at least, quite accessible. Now, another question that I used to get constantly was, is it safe to actually lower cholesterol? How safe or how low can we get? And can we be intensive? And over the years, the data has gotten to the point that we now feel very, very safe with very low cholesterol. These graphs here in orange, the top of the graph is the pre-treatment, the average baseline cholesterol, and the bottom of the graph is what the on-treatment LDL was. And you can see over the years, it's been pushed lower and lower to the point now where with the new PCSK9 drugs, we have pushed people's LDL cholesterols to extremely low levels, below 1 millimole. In the US, below 30 milligrams per deciliter is very common now to see. And so we are very, very comfortable with reducing cholesterol to low levels. This is also reinforced by data from human genetics, where people are born with very low cholesterol. And for the most part, they are extremely healthy. They have no problems with birth, infantile range, failure to thrive, growth, puberty, having children, getting jobs, being athletic. They have no problems at all, even though they have very, very low cholesterol. And then, and we have data to back up that this is very solid ground. In the 4-year study, which is a study of a PCSK9 inhibitor, 10% of the patients in the study, by the way, the study had almost 30,000 patients in it, but 10% of the patients in the study reached extremely low LDL levels. And when the investigators looked at whether or not that group had more adverse events than everyone else, or even individuals who did not get their LDL lowered much like the placebo group, there was no increase in adverse events. And that reinforces that very low cholesterol is safe. Now, there's a lot of other things that people talk about in terms of cardiovascular disease or reducing cholesterol, cardiovascular disease, and the risks of reducing cholesterol with statins. Most of these are not backed by much evidence. Hemorrhagic stroke is something that may show up in large data sets, but generally speaking, it's not something that shows up in statin studies, particularly, at least not to a point that we worry about it per se. Effects on cognition, if they happen, they're extremely rare. There was someone at the US FDA, the Federal Drug Administration, who this happened to. And so because of that, it's talked about a lot. But it's very easy to deal with. If it happens, you simply switch to pravastatin and it goes away. Effects on liver, this is actually so uncommon that the US FDA has now said that we don't have to check liver enzymes any longer in people on statins unless they have an ongoing liver issue. Proteinuria is something that may happen with high doses of some statins, but it does not cause any long-term effects in the kidneys. New onset diabetes is something that is talked about a lot, but it's not something that probably is clinically relevant. In order for someone to be pushed from pre-diabetes or be pushed into diabetes from a pre-diabetic state on a statin, they probably need to be on a high intensity statin, and they probably need to have had a pre-existing metabolic issue like pre-diabetes and not deal with it. So when we put people on statins and they have metabolic syndrome or pre-diabetes, we tell them, focus on your weight, focus on your diet, make sure that you take care of yourself. There is a small risk that perhaps your A1C or your glucose level pushes into the diabetic range, but that risk is so small that it's still not worth withholding statin therapy. Muscle symptoms are another one that, if it happens, it typically happens in the first 3 months. It almost never happened in randomized controlled trials. And that might be because they pick people to be in those studies that don't have too many comorbidities or are not on many other medications. Most of the times that the muscle symptoms happen, they do happen because of some interaction with another medication or because of someone who is genetically prone to have it. There is a very, very small number of people who get rhabdomyolysis. There's another small number of people who get myositis. And then there's another entity called autoimmune necrotic statin-induced muscle myositis. That is a very, very rare condition, and it can be picked up by antibodies, HMG-CoA reductase. But again, very, very uncommon, not a reason to withhold statin therapy. I will say, if someone has an underlying neuromuscular disease like myasthenia gravis or something like that, I usually don't prescribe the statin. I go to non-statins. That's the only exception that I really have of giving statins as first-line therapy for most people. Cataract was something that people were scared about, but honestly, there's no evidence that statins increase the risk of cataract. And so the cardiovascular benefits of statins greatly outweigh the risks. And I mentioned a lot of this already, but really there is no, all of these are very, very small things that are picked up only when you study large groups of people. So what is the optimal dose of statins? As I mentioned, we have 7 different statins now. 6 of them are generic. The only one that's not is pitavastatin. For most people of South Asian ancestry, they should probably be on a high intensity dosage. If they have any risk factors for cardiovascular disease, my opinion is that they should be on a high intensity statin, and that would be atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams. And the US Preventative Task Force, which is one of the most conservative groups to make recommendations, recommends moderate intensity statin for primary prevention. And the American Diabetes Association, which handles a lot of diabetes patients, recommends high intensity statin for secondary prevention. And is this a lifelong therapy? Yes, it is. People have high cholesterol due to various reasons. Some may be environmental, like due to obesity or something, but that's not usually the case. If they have high LDL, it's going to be there regardless of what you do to their diet or exercise. You can change it somewhat, maybe up to 20%, but usually that's not enough for people to really reduce their cholesterol enough to make a huge difference. And so stopping statin therapy prematurely is not a good idea. It generally does reduce the cardiovascular benefits of it. So what statin is better out of the two high-intensity statins? I mean, the most important thing is just to get your patient on a statin if they need it. But there are studies showing that rosuvastatin may be slightly better than atorvastatin. Rosuvastatin does lower LDL just a little bit more than Lipitor or atorvastatin does, which would probably explain it. So I will stop there. I think I went over my time a little bit, but in summary, South Asians are at a high risk for atherosclerotic cardiovascular disease. Cholesterol is a modifiable target. That's really important. We need as many modifiable targets as we can get to reduce the risk of cardiovascular disease in South Asians. And reducing cholesterol robustly reduces the risk of atherosclerotic cardiovascular disease. Statins are first-line therapy to reduce cholesterol. They actually have a great safety profile, and they need to be prescribed more frequently. And so thank you very much for the time. I really appreciate it. Again, I apologize for going over time.
Thank you, Dr. Zahid, for an excellent review on what is relevant in changing the CV outcome. You highlighted very well about the role of statin, the intensity of lowering, the degree of lowering, the targets, therapy, and the doses. To start with the question, and we have Dr. Aditya Kapoor joining with us. So I have two experts, one lipidologist, Dr. Aditya Kapoor is a cardiologist, and I'm an endocrinologist. So we'll start with Dr. Aditya Kapoor first. Dr. Kapoor, Zahid highlighted about Southeast Asians in relation to UK Biobank study. Now, I would simply ask why Indians are more susceptible to develop coronary artery disease. And probably a point highlighted was 1 decade earlier.
Yeah.
We highlighted a point of age 40 years, but by and large, we all physicians know Indian get much early. So would you explain what is behind all this early vascular damage in our population?
Yeah. Thank you. Am I audible?
Yes, you are audible.
So first of all, my compliment, Dr. Zahid, fantastic lecture, and we would have loved to listen to you more, and you did not exceed your time at all, so be rest assured. And, you already mentioned about the biobanks data, and you mentioned about the Indian ethnicity. So all of us know that we are in the middle of an AVSCD epidemic, and our ethnicity predisposes us. So there is some genetic angle to it. And number two, as Dr. Shah also said, there are certain other factors. So if we briefly want to enumerate them, there could be one is the dietary patterns. Our traditional diets include a high level of saturated fats, refined carbohydrates. There is a very high prevalence of metabolic syndrome in India, which is characterized by obesity, insulin resistance, dyslipidemia, hypertension. Then you have smoking and tobacco. You mentioned the modifiable and the non-modifiable risk factors. So Indians have that unique, adverse combination of both non-modifiable and modifiable risk factors. Our ethnicity is the one which is not modifiable. And of course, amongst the modifiable, we have the tobacco and the smoking use, the bad diet, sedentary lifestyle, stress. Again, if you look at India now, rapid urbanization is there, socioeconomic disparities are there. So these are often unlooked factors. If you remember the Interheart study, which also touched upon these 7 or 8 factors, among which psychosocial stress was a often neglected factor. And then there is recent data to show air pollution. Me and Dr. Shah were talking about it a couple of days ago. So urban areas in India often have a high level of air pollution, which is again an unrecognized and often now being recognized as a risk factor for cardiovascular disease. And last, another important thing is the lack of healthcare access and awareness. So all these factors play a role that Indians, apart from the genetic predisposition, there is a lot of problem with diet, sedentary lifestyle, tobacco, smoking, other environmental factors, and of course, late health seeking or, a bit of a laid back health seeking behavior. So all these contribute to a higher prevalence of CAD in India.
Thank you, Dr. Aditya. One of an important contributor in our healthcare system is all the outdoor care is not being reimbursed in any insurance system. What is prevalent in US and in many other countries, outdoor care is also being funded. So that is an important point in relation to compliance of medication for a silent disorder like hyperlipidemia. Dr. Zahid, you mentioned about South Asian. Are they similar whether they are in UK or USA or India? Do you think
Yeah.
they have similar risk carried over everywhere? They live similar lifestyle, or they are better off in those your countries?
Well, I can answer that very quickly. They're not better off, unfortunately, not in terms of cardiovascular risk. But there is plenty of data from UK, US, showing that people who move here are still at risk, same risk, a very similar risk of cardiovascular disease. Now, they may not change their diet, they may not change some lifestyle things, but they would be exposed to less pollution. There are some things that would be different here. But regardless, the risk of cardiovascular disease is quite high. And not only those people who have moved here, but their offspring are still at very high risk of cardiovascular disease. And so it may be genetics, and the genetics may be related to things like body fat distribution, insulin resistance, and that may accelerate atherosclerosis. I mean, my own father moved here in the 1970s, and by the time he was 35, he had 2 heart attacks. Even though he had changed countries, it still didn't reduce his cardiovascular risk.
So, right, one more point you mentioned in the risk factor was age, sex, race, and women in particular do not receive that kind of a statin you mentioned. Which kind of a women need, or they are at higher risk and they need equally a good cardiovascular care? First, you will answer, and then Dr. Aditya would answer how frequently you see women as a patient for intervention.
That's a good question. Certainly, cardiovascular disease is more common in men, but women also get it. And unfortunately, we sometimes ignore women when they complain of chest pain or things like that. So the women that we make sure get treated early, even during reproductive years, are the ones who have cardiovascular risk factors. And so if they have any of those risk factors for cardiovascular disease, we definitely make sure. The group that is at probably the highest risk in terms of women is those with familial hypercholesterolemia. So those are the ones who have the LDLs above 200, above 190, 200, whichever cutoff you'd like. And for them, they should be treated as early as 9 or 10 years of age. I mean, it's for women, their risk of cardiovascular disease is more like a man than a woman. So depending upon the risk factors, how high the LDL is, those things dictate, when you would treat a woman. But there is there's a huge disparity in terms of who gets cardiovascular disease and when they get treated with statins and whatnot. And women tend to get treated less often, even though in some cases they have the same risk as men.
Dr. Kapoor, 52 women with 50 to 80 age group. How frequently?
Yeah, very interesting question. And again, it's a very relevant question because of late, as Dr. Zahid also mentioned, we are noting the gap between the genders is narrowing. I mean, it's still there. So now at least, I would say from the top of my head, maybe about 1 in 4 or 1 in 5 females in our clinical practice still undergo intervention. That's what I'm talking about for ACS. So we are now noting that women are coming in with ACS, and the women who we would like to treat as a high risk group, as Dr. Zahid also mentioned, the one with comorbidities, of course, diabetes, hypertension, dyslipidemia, but post-menopausal women. That is another high risk group which we are looking at. And of course, those with a family history of coronary artery disease or with some genetic predisposition, obesity, etc. So these are the women we target more aggressively.
Dr. Kapoor, diabetic women are at very, very high risk. And so do you think that diabetic patients who need a primary prevention, most of them in presence of one additional CV risk factor, should receive a statin? And there is a question from audience I would like you to answer together, that diabetic patients should be prescribed 10 milligram atorvastatin or rosuvastatin 10 milligram. So that would be your second question in continuation of diabetes population.
Again, diabetics are a different ball game altogether. And as we know from the old Swedish data that was 30 years ago, that landmark study from Sweden, which showed that diabetes is a risk equivalent, just like a myocardial infarction. So these patients are, of course, high risk, we know, because of very, very important risk factors like insulin resistance, hyperglycemia, co-association with diabetes, with dyslipidemia, hypertension. They have a pro-inflammatory milieu, increased inflammatory response, platelet dysfunction, coagulation abnormalities. So, in my opinion, what we have been talking to our endocrinologists also, and maybe you are an endocrinologist yourself, so you will vouch for that. That in my opinion, diabetics, especially of the age of more than 40, who have had diabetes for a long time, and especially those with target organ damage, they have to receive a moderate to high intensity statin. There is no question in my mind. When I would probably put all of them on a moderate to high intensity statin. So I would seek the others' opinion in this, because we have to have a very, very aggressive approach in diabetics. And that is what the Western guidelines also endorsed. And now the LAI guidelines, also the Lipid Association of India guidelines, say that diabetes with or without ASCVD have to be treated very aggressively with a moderate or high intensity statin.
So primary prevention also needs a different kind of a dosing.
I would say yes. I mean, what does
Dr. Zahmad, what is the practice in US preventive clinic? What is the epidemiological data? And what's the practice in UT Southwest?
Yeah, the epidemiologic data is pretty clear that diabetics, similar to what Dr. Atithya said, that they have much higher risk of cardiovascular disease, almost as if they've already had cardiovascular disease. So the practice in the US, the guidelines here would say that if you have a diabetic patient, you assess their risk factors. We use the ASCVD risk calculator. If they have high risk, then you would put them on high intensity statin. If they have moderate or low risk, then you would put them on a moderate intensity statin. And so, and the calculator that we use is the traditional risk factors, age, ethnicity, race, gender, smoking, diabetes, hypertension medicines. We have new calculators that are a little more sophisticated, but that's still the basics. So if they have any additional risk factors, they pretty much end up on a high intensity statin.
So there is one question from audience regarding loading dose of a statin. So do you think there is anywhere a place Dr. Aditya would answer in relation to all hospitalized patients? But before that, in an outdoor setting, do you think there is anything like a loading dose of a statin? You might see in a familial hypercholesterolemia and kind of. I do not understand a word called loading. We need kind of a high intensity is prescribed similar to moderate intensity. Dr. Kapoor, is the loading dose probably applied. The story started with atorvastatin 80 milligram kind of a thing.
So, it is more relevant to admitted patients, especially with acute coronary syndrome undergoing coronary intervention. So there is data to show, convincing data to show that if you load them with high intensity statin, and you are right that the story started with the atorvastatin, and there is convincing data to show that if you load them with a high intensity statin, either atorvastatin 80 or rosuvastatin, which many institutions follow, that any patient who comes with an ACS is undergoing an coronary intervention. So the loading is a pretty standard protocol in many institutions, and it is effective.
Kapoor, there is also something like people who received such kind of a loading dose, they were discharged on high intensity, and subsequently treating physicians and primary care people tend to reduce the dose looking at an LDL level. And even they compared a little long-term outcome between the two groups who continued higher dose versus lower dose. So what's your take on kind of continuing high intensity versus moderate intensity? Clinically stable, but long-term outcome.
Yeah, again, so this is very pertinent question. And you are right that often the mindset of physicians is that, say, the patient comes back in the OPD after being on a moderate or high intensity statin. So they look at the LDL reports and the mindset is to sort of downscale the statin dose downwards. But I think it should be desisted from. And as Dr. Zahid also showed, that initially the LDL, the ACC guidelines also endorsed that. The older guidelines used to say that you can downscale the dose by 50%. But now there is, again, the guidelines have been revised and there is no recommendation to downscale the dose. And the data, as Dr. Zahid also showed, lower the better. So that is an intuitive mindset which we should shy away from. I don't think there is any need to lower the dose of statin if the patient is tolerating it well, even if the patient is stable. Because our idea of stability, we are not even sure what is stability. It is the patient is walking around doesn't mean he's stable. The plaque may be still vulnerable. So I don't think we should down-titrate the statin dose. We have to continue in the same dose. And say if the LDL comes down really, really low, even 30, 35 we have achieved and the patients are doing well. And he also showed some data that, the PCSK9 trials have showed people getting it down even to 15 to 20, although that's not a clinical recommendation. But I don't think we should down-titrate the dose just based on lipid values.
So, Dr. Zahid, there is a question which emerges in relation to the strategy. One is a LDL-oriented, target-oriented statin. Another is a percentage reduction to be achieved with a statin. So what do you think? What should be the strategy when it comes to people had been looking at 70 milligram LDL in milligram terms? They achieved with a simple dosing versus 30% reduction taking them to 70 versus another dose which reduces by 50%. So target oriented versus percentage reduction.
Yeah, so this comes into play when you choose which statin you want to use, because if you choose high intensity, you're looking at 50% reduction. If you choose moderate intensity, you're looking at 30% reduction. And so you could look at it two ways. One is what is the intensity they need, the percentage reduction, or you can look at it as they just need something. And so in the US, for the most part, if they have cardiovascular disease or are at high risk, you put them on a high intensity statin, and then a few months later, recheck the lipids and see where it's at. And we talk about threshold to treat. So if the LDL remains above some threshold, then we add on therapy. So let's say you start a patient today on rosuvastatin 20 milligrams. They come back in 3 months and their LDL has dropped by 50 or 60%, but it's still 81, or still 90 or 100. Well, if they are high risk or they've had previous cardiovascular disease, we would add on therapy, maybe ezetimibe or something else. So we start with the intensity of statin, and then the next step is to treat the LDL to a threshold. So it's a combination of those two things in the US at this point.
So do you think there is still a more pleiotropic effect if we continue the dose with lower LDL level? So there would be still another trick to that question is whether I use a 20 milligram of rosuvastatin versus 10 plus 10 as a combination. Which one is more superior? Because both might take me to a similar target. So ezetimibe 10 and rosuvastatin 10 versus 20 rosuvastatin. What would be your approach in the clinic?
So my approach in the clinic, again, we would first put the patient on a statin and then see where they're at. And one question we often face in the clinic is, do we double the dose of statin? So if they're on Rosuva 10, do we double it to 20? Or if they're on 20, do we double it to 40? Or do we add on therapy? So here's where the cholesterol panel, the LDL level, comes into play. If they're near their goal, near their threshold, then we may just double the dose of statin. Because doubling the dose of statin typically reduces LDL by another 5 to 10%. If they're not close to goal, then we may choose ezetimibe or a PCSK9 inhibitor. because ezetimibe would reduce the LDL by 20% and PCSK9 inhibitor by a very impressive 75% in many cases. And so it's a bit of a tailored approach. We do recommend that people think about the follow-up. Initially, they shouldn't think about it. Just put the patient on a statin. If they have high risk, put them on a high intensity statin. Don't think about it. But then later on, follow, see what you need to do, tailor the therapy to each individual.
And Dr. Zahid, what is your, and I would also like to ask Dr. Sanjeev, in your clinical practice about down titrating the statin dose, if the patient is doing well and you discharge him on say 80 or 40, what do both of you do actually in your clinical practice? Do you downscale it, or what is the practice in your place and Dr. Sanjeev?
No, I fully understand that side effect is not linked with any kind of a dosing of rosuvastatin. I also know and make it aware to listeners as well as Dr. Zahid that Eris is at forefront of keeping a flat price for 10 milligram, 20 milligram, and 40 milligram at rosuvastatin. So no change in the price, including ezetimibe combination with 10 and 20, all at the same price. So in relation to cost consideration, I have no reason to change and continue with the same 20 or 40 milligram, what has been initiated, what is required. And in all the patients who have been subjected and are part of secondary prevention, they continue the dose which has been recommended by cardiologist, which is frequently, most of the time, high intensity statin.
Dr. Zahid, your practice?
So it would be very unusual for me or my colleagues to reduce the dose of a statin. It does happen. In some cases, there are people who have adverse events. In that case, you may reduce the statin because that might reduce the chance of further adverse events. And in some cases, someone's cholesterol gets so low that they themselves are scared of it, like LDL of 1 or 2. But generally speaking, that's not the case. And at least ever since the PCSK9 studies came out, we are very, very confident that lower LDL is safe. And so we would not downtrend because the LDL is too low. That's the most common scenario we run into with regards to downgrading the statin.
Dr. Zahid, there is a question from audience. How would you manage familial dyslipidemia in pregnancy?
Yeah, okay, that's a very, very important question. One, people who have a familial hypercholesterolemia or dyslipidemia of some other kind, they do require treatment early in life, including women. And so, and women of reproductive age, historically speaking, we used to think of statins as being teratogenic. Now, the US Federal Drug Administration, the FDA, has loosened that, because in their registry, there seems to be a very minimal risk of statins in pregnancy. So now we're no longer scared of giving someone a statin if they're reproductive age. But the FDA still says that if you find out they're pregnant, you should probably just stop it. If it's safe to stop it, you can stop it. But there are some women we see with LDLs of 1,000. We would not stop it in them. They may have a condition like homozygous familial hypercholesterolemia. You cannot use statins in breastfeeding, though. So if after the child is born, the mother decides to breastfeed, then we would have to stop it for some time. If you're looking for another agent that can be used in pregnancy and breastfeeding, that would be bile acid sequestrants. These are drugs like colestipol, colesevelam, cholestyramine. They are, at least 2 of them are very, very old. They predate statins, and they work in the intestine by binding bile, and they don't get into the systemic circulation or breast milk. And so they would be the safest options in pregnancy. Occasionally, in the worst cases, we have to do a procedure called LDL apheresis, which is physically removing cholesterol from blood. But that's very, very rare. And so that's the approach. Nowadays, we're not too worried about women being pregnant on a statin. We do stop it if they do get pregnant. And we're very careful about the breastfeeding period because we don't want the baby to be to get a statin. We don't know the effects of statins in breast milk that are transmitted to children.
So Dr. Aditya would like to leave in 5 minutes. So there is a question for you in relation to how do you select ezetimibe versus bempedoic acid with statin in Indian patients? Bempedoic acid had been there for a year and ezetimibe was an additional option. So between the two, how do you think of using if you have used in 1 year's time?
What we are doing in our OPD now, Dr. Sanjeev, is that, as Dr. Zahid said, most of the patients who are getting discharged now, as we were discussing, the Cardiological Society of India has put out its own guidelines. So for acute coronary syndrome, we are discharging on statin plus ezetimibe. Bempedoic is put on as an add-on therapy if the patient doesn't achieve their goals during the outpatient visit. So at present, still our practice is focusing on statin, ezetimibe, followed by bempedoic. So it is not the other way around. I mean, we are not starting bempedoic before ezetimibe because, based on the improved data also and the guidelines which endorsed ezetimibe prior to bempedoic. So we are using statin plus minus ezetimibe followed by bempedoic. And now what we are doing in our OPD again is that we have a point of care testing lipid panel as well. So because ours is a tertiary care center, we're surprised to note that at least 30-40% of the patients who are coming back, they are still not in goal. So we are adding bempedoic to them.
So probably our comfort level with ezetimibe is much more with IMPROVE-IT and a racing trial, very convincing data. Dr. Zahid, there is a question in relation to how to manage elevated lipoprotein A. I don't know whether you are part of CIRNA trial or not, or any of the CIRNA is regularly practiced or not at your center.
Some of my colleagues are site primary investigators for the lipoprotein A clinical trials of new drugs that are being developed and are actually very close to probably having outcomes data. So as you know, lipoprotein A is high in many South Asians and is a risk factor for cardiovascular disease. What we do not know is whether or not reducing lipoprotein A actually reduces cardiovascular events. There's lots of conflicting data. Genetics data would say that people with lower lipoprotein A have fewer cardiovascular events, but statins raise lipoprotein A levels, and yet they reduce cardiovascular events. And so that question is still out there and still needs to be answered. And we will have an answer because these new drugs are very targeted. They only lower lipoprotein A, and they lower it a lot by 80-90%. And so soon we'll have an answer whether or not we should focus on lowering lipoprotein A. But if I do see someone who has high lipoprotein A, I certainly make sure they're on that we lower their cholesterol as much as possible and they live a healthy lifestyle. Those are the most important things.
So probably the subject of residual risk had been there for quite a long time. So in relation to that residual risk, the point of LPA comes. So in relation to that, there is another question also. Should triglyceride be treated to target with statin? So probably I'll take it there that triglyceride lowering drugs should not be considered first. First, a statin should be used and see that with improved lifestyle, TG reaches the goal or not. The guideline recommends to reduce below 200 triglyceride. Statin will reduce by 20%. And they have asked what is the ideal dose in high-risk patient. I don't know the dose what they are asking, but the triglyceride lowering drugs are fenofibrate and saroglitazar, which reduce close to 50% triglyceride from baseline. But very severe hypertriglyceridemia still does not reach 200 milligram level. And those are at high risk of pancreatitis, and we keep seeing in diabetes clinic. Dr. Zahid, any suggestion in relation to very high level of triglyceride, more than 1,000, which do not reach the target level of triglyceride? How do you manage those patients?
Yeah, it can be very difficult. We certainly have a lot of patients like that here in Dallas. And so we put them on fibrates, we put them on omega-3s. The other very important part of their treatment is extremely low-fat diet. So remember that triglycerides are fat. And at some point, the main enzyme that clears triglycerides, which is lipoprotein lipase, at some point that gets saturated. Remember, all enzymes have a saturation point. And for lipoprotein lipase, that saturation point is probably around 800 milligrams per deciliter of triglycerides. At that point, it is very hard for the human body to clear out more triglycerides. The best thing you can do is reduce the input or reduce the intake. And so we often put them on an extremely low-fat diet. Then the next trick I have is to use a drug called Orlistat, which is it's actually available over the counter in the US. It's a weight loss drug. It's approved as a weight loss drug. It works by blocking an enzyme in the intestine called intestinal lipase. And that then reduces further 30% absorption of fat from the diet. And I have been very successful with this approach. I've seen people with triglycerides of 20,000 and using this approach, especially the low-fat diet part, within 2 weeks, it'll drop down to 1,000, and in a few more weeks, it'll be in the 500 or lower range. Our goal is typically to drop those people to below 500 triglycerides.
Any
hopefully
comment,
that
Dr.
helps.
Aditya, or we go ahead with the last question for Dr. Zahid? Any new drug coming out from Dr. Helen Hobbs' laboratory, who is working on NAFLD and hypertriglyceridemia, all various genetic pathways of NAFLD, now called MASLD.
Yes, now it's called MASLD. Her lab, she shifted her lab from mostly lipids to MASLD or NAFLD, and they have done some amazing work, groundbreaking work on identifying which people go from just fatty liver to the steatosis to fibrosis to cirrhosis. I mean, it's really groundbreaking work and developed a lot of insight. I'm not sure that any of the things that she found were drug targets, but there is a new drug for MASLD available in the US now. It's the only drug that we have to treat it. It is a thyroid beta receptor agonist. And beta receptors for thyroid are almost only in the liver. And if you activate them, you somehow reduce the fat in the liver and even reverse the fibrosis a little bit. This is a New England Journal paper, sometime recent, and the FDA just approved it literally weeks ago. We don't have it in clinic yet, but we will soon.
And we haven't got yet a drug in relation to leptin pathway from Philip Scherer's lab, who was to get a drug for NAFLD. He has patented a molecule.
Yeah, for leptin?
Yes,
for
for
adiponectin?
NAFLD from Philip Scherer's adipocyte biology lab at UT South.
Yeah. No, I know Philip Scherer very well. He's also a mentor of mine. So leptin, there is a drug available called metroleptin, but it's only for people with acquired generalized lipodystrophy or congenital generalized lipodystrophy. Those people have no body fat, no subcutaneous body fat, and very, very low leptin. And if you treat them, they actually do improve the fatty liver. But in the general population, if you give leptin, it doesn't change the liver fat. It doesn't change anything because we all have very high leptin levels already. We have plenty of fat. And so it'll probably never be a drug that is for the general population.
So with that, I would thank Professor Zahid Ahmad. I would thank Dr. Aditya Kapoor and close the session. We are exactly at 9:33, 1 hour from the time we started. Over to you, Khushbu Patel, for vote of thanks.
Thank you. Thank you very much, all the doctors, for being part of the speaker panel. Dr. Sanjeev Shah, Dr. Zahid Ahmed, and Dr. Aditya Kapoor. It was really a very insightful session. And the expert opinion from your clinical practice, especially, it helped answer many questions which doctors had today. And I'm sure all the clinicians really enjoyed the insightful discussion on lipid as well as statin. So thank you very much for sparing the time, and wish you good day, sir, Zahid Ahmed, sir, and wish you good evening, all other doctors. Thank you.
Thank you so
Good
much for
weekend.
having me.
All-
Thank-
Thank you. Thank you all doctors to be part of this evening. Thank you.